Good morning, everyone. It is still Friday. You're back in the House Healthcare Committee, and in our continuation of hearing about budget requests, we have Pathways with us today, so welcome. And they will walk us through their budget ask. This is not in the governor's recommend, so again, this is something we will consider on top of what's in the governor's recommend. And we have Hillary Melton with us, Executive Director of Pathways, and then Jason Young, who's the Program Manager for Soterra House. So why don't we do some quick introductions so you know who you're talking to, and then we'll turn it over to both of you. So Art?
Yeah, my name is Art Peterson, Representative Art Peterson. I represent Clarendon, Wallingford, West Rutland, and a piece of Rutland Town.
Leslie Goldman, Wyndham 3, Rockingham, Westminster, Brookline, the Bells Falls area.
Hi, Daisy Rebecco. I represent Winooski.
And I'm Topper McFawn. I live in Barrytown, represent Barrytown and a piece of Williamstown.
Lori Houghton, City of Essex Junction.
Brian Chena, Burlington.
Alan DeMar, representing Enosburg and Montgomery.
Bobby Farley's Rubio, I represent Barnet, Reigate, and Waterford.
And
Alyssa Black, Essex.
great. So if you can both introduce yourself for the record and then start your testimony.
Sure. I'm Hillary Melton. I'm the Executive Director at Pathways Vermont.
My name is Jason Young, and I'm the Program Manager at Soterra, Vermont.
I've been here many times before, but there's some new faces. So I'm going to give you a brief overview of what Pathways does. And then Jason's going to walk us through the ask for the program that he manages, which is Soterra House. Pathways Vermont is a statewide organization. We provide mental health and housing services. We're in every county, but we don't provide services. Not all of our services are available in every county. We have 145 staff. We're funded by the Department of Corrections, the Department of Mental Health, the University of Vermont, UVMMC, HUD. We bill Medicaid for some of our services. We're designated by the Department of Mental Health as a specialized service agency, which means we work alongside the designated agencies with a specialty in Housing First. Housing First is an evidence-based practice for ending homelessness, and we're Vermont's expert on Housing First. We're an integral part of the system of care. We catch many people that have fallen through the cracks. In addition to our expertise in permanent supportive housing, we run several peer services. We have the Pathways Vermont support line, which is a statewide support service. People can call from anywhere in the state and receive peer support. Last year, we completed 14,000 calls with that service. We have a community center in Burlington, Pathways Vermont Community Center. You can get meals, showers, employment support, peer support. It's a place for community and connection for folks in the Burlington area. And we have Soterra House, which is also a statewide program. Anybody in the state and it can go to Soterra House. Jason's going to tell you more about that. It's located in Chittenden County. Pathways also facilitates the coalition of peer-run agencies in Vermont, and we're working on statewide certification so that peer services will be able to bill Medicaid for services and thereby being able to, we hope, open more doors to peer services. We're at the State House today because we think we're very good at our specialties and we think we can help more people. We're also very good at saving the state money. Our work keeps folks out of expensive institutions like hospital wards, prisons, shelters, and motels. This year, in addition to the ask for Soterra that Jason's going to walk you through, we're asking for, just so that you know, we're asking for more money for Housing First services to make them statewide. Last year, you all, the legislature funded us in Bennington, so we were able to expand our services to Bennington. The Bennington delegation did a really great job supporting that effort. And we're asking to continue to get more funding so that we can be statewide, so that everybody has access to Housing First services.
And so is that request going through general housing?
Mm-hmm.
Okay.
We were there
We
yesterday.
haven't seen anything.
Yes, and I'm meant to send it to you all. I will forward it afterwards.
Yes, that's great.
And then we did send a video. It's 10 minutes long. It's a lovely video of 3 residents of Soteria House talking about their experience. So we couldn't have somebody here today. It was really well done, made by one of our staff people at Soteria House. I would just love it if you could all watch it at some point, and you'll get a real feel for what we do there.
Great.
And I'll turn over to Jason.
Haley.
So before you start, Jason, we have.
I was just wondering if you could submit that testimony that we could,
What testimony?
that she just read? I didn't know about how the different
Oh,
funding
sure.
streams. That was very interesting to me, that it's like 5 different places and.
So there's also just, you can actually look on so please submit it.
Yeah, yeah.
But if you look on previous sessions on our committee page under Hillary's name, we have quite a bit of information that'll explain what Pathways is. I think we have some actual brochures on the committee page. So, but please, if you can, submit the written testimony as well.
I'll take it out of bullet form.
Thanks. That's fine. I like bullets.
Great. Thank you, Jason. Go ahead.
Yeah, thank you. And thank you all for making, a few minutes for us to advocate for this important program. I'll just give you just a really quick picture of what Soteria is, what we do, why it's different, why it's important, and why this funding is important to move us forward in our mission forward. Soteria is a residential mental health service. It's a licensed therapeutic community residence, so it's licensed and overseen by the state. We currently serve 5 individuals at any given time. That's maximum capacity of our current house.
And can I just say that that's beds? So you have 5 beds. Okay.
I avoid that terminology. It's a little too.
I know.
But
I apologize, but it's how we determine, is it how, sorry,
I've bed.
What language do you prefer, though?
right.
I use non-clinical language, so we have spots for 5 people. We can serve 5 people.
Or space?
Yeah.
Okay.
Yeah.
Are they all full?
We have a very very good track record of being full. Yeah. I think we are above average in the state of Vermont in terms of being at capacity. Yeah.
Thank you.
Sure. So what makes us really different and important, I think, is that we're early intervention, trying to connect with people really early on in their lives when they're experiencing like their first crisis. And practically what that means is, while most residential programs in the state of Vermont operate as a step down from the hospital, people will go into crisis, go to the hospital, then come out into residential program. But we're actually trying to connect with people before they go to the hospital to avoid that entirely, right? So that it really is a very different model in many ways, but that's one important way. We're also, because of that, we have structured, like our intake is extremely accessible to people, because people in crisis need to be able to connect with services easily without a lot of barriers and paperwork and that kind of thing. So while most residential programs have a very complicated referral process that does involve external agencies and that kind of thing, a family or an individual can call us directly, set up an interview, and go to their home, interview them, and if they meet criteria, we can have them in the program the next day, right? So it's very like a streamlined process. It's very accessible financially. We have a sliding scale. We do potentially charge fees. We don't accept insurance, but we have never turned away an individual based on the lack of funds. So we've got a flexibility on that sliding scale so that the accessibility is there in process, financially, and in every way. It's also a much more extended support than in many ways than other programs. It is supposed to be short-term crisis service, so it's 3 to 6 months. But after that initial residential experience, we offer 6 months of a transition program where we stay in touch and offer a far more limited set of services in the community. But it's another 6 months. And in addition to that, we have regular events at the house twice a week, actually, where we invite any former resident to come back and enjoy a meal with in the house with the current residents. So people can stay in touch for years and do in a limited way, but they establish these relationships. It creates a long-term stability for people. They can come back and check in and still feel connected. We also, at another level of maintaining connection with people, we have 4 staff right now who are former residents. So people have a deep connection to this program. It's not something they come through, to have a superficial experience and then move on with their life. Although some people do. I mean, some people can leave and thank you and we never hear from them again. But the potential for remaining in contact and investing back into the program is there. So yeah, we out of 15 staff, we have 4 people who have come to the program. In fact, I co-facilitate support group for friends and family of people in crisis with the mother of a former resident. So it really does start to feel, it has become a real community has a permanence for people, a stability for people over the long term. I think this is a really important model. We really, even though we operate under the same licensing and oversight as all the other therapeutic community residences in the state of Vermont, it's a very different animal. We operate very differently. And I hope that, comes through today. The people who would otherwise be removed from their communities, put in a locked ward and treated through conventional sort of medical model, psychiatric services, are allowed to stay in their community, stay connected to their friends and family and their natural supports. It's a non-coercive setting. We don't lock doors. If people leave and we're worried about them, we go with them and we maintain safety on a individual basis in that way. So we're doing this amazing thing, and we're already doing this amazing thing. So I think the question here is like, why are we asking for these additional funds? And I think that owning this building is gonna support the sustainability and stability of this program over long term. Anyone who's moved from renting to owning a house knows that's a big difference, right? And both financially and sort of psychologically. Even though we have a wonderful relationship with our landlord, he's a landlord, and maybe he'll choose to sell the building or lease it to someone else. That would be either inconvenience for us and our residents. And I think the most important thing here is that this is going to allow us to purpose build this space so that it's more functional, more accessible, and I think most importantly, safer, right? So we're working with a very good design team who have suicide prevention in mind, have the safety of the residents in mind. So there's an extensive conversation about how do we design this building to serve people better. And there's a lot in the physical plant that can support that. So this would be a big step for Soteria.
And my understanding is it is increasing the number of spaces,
Yes,
right?
thank you. Yes, almost doubling capacity. A very big impact on. I think last year we had to turn away 45 individuals who would have met criteria because we didn't have a spot for them. So there is a need for this in the state.
Great. And it's a collaboration with others in the community, if I'm correct, for the funding, or, because I don't think you're asking, I think there's already funding that's been.
Yeah,
I apologize, I don't have the proposal up in.
It's just individual donors. We've raised 500,000 already.
Okay.
And we're asking for 987, I think it is.
985.
Thank you, sorry. 985. Yeah.
Great.
It's a Champlain Housing Trust building. It's downtown. It's kind of dilapidated right now, but it's got good bones. Yeah.
Topper, and then, so can we ask questions? Are you ready for questions?
Yeah.
Okay, great. Topper and then Brian.
Maple Ave,
Yes.
familiar with Burlington. Are there any zoning laws that you're gonna have to deal with?
No, it was a transitional residence for people coming out of corrections. People coming out of corrections, so it's got the same zoning, the right zoning. We're not going to have any issues. But that's a good question. Thank you.
Yeah. Brian?
Yeah, I have a few questions, but I'll start with the one related to the location. Is this, I'm looking on Google, is this what used to be the Spectrum SRO many years ago?
Yes.
I've been in that building. So it's great that you want to repurpose it for a similar, well, it's not even repurposing, that you want to like keep it as a transitional, well, it's not even transitional housing what you're doing, but as a residential supportive housing, that's what I would call it, like a supportive housing. So that's great. What I wanted to ask is a few questions just about like the how I do support the idea of giving money to purchase the property, but the question is, how do we continue to support you? Like, so you don't have to, I don't know, fundraise from rich people or whatever we have to do to fund, you know what I mean? Like, how can the state support? And I'm wondering if you could explain a little bit how the program's currently funded, like why you can't take insurance, and also if peer certification might help you get insurance once we have that.
Yeah. So we're hopeful for the peer certification for sure. We're not set up to take private funding. We're funded through the Department of Mental Health, which is a combination of Medicaid dollars and general funds. So we have a base part of in the base budget for Soteria, and a commitment from the Department of Mental Health to continue to fund Soteria. So that seems solid.
So can I just, sorry, can I follow up with a question on that?
Yes.
So why can't you take commercial insurance? Is it prohibited by DMH? Or is it a philosophy of having the openness of accepting everyone? Or something completely different?
I don't know. We're not set up for commercial insurance, and it's never come up.
Okay, because Pathways in general doesn't take commercial insurance, right?
We work with people who are living in poverty, so it doesn't often come up.
Okay.
I guess is why. So
Okay.
we don't have the infrastructure set up because it's
you don't
not.
really have the.
No, and most people that come to Soteria don't have incomes or insurance.
Okay, thank you for that. You want to keep going and then I'll.
Well, it's just because I think it's important that the state prioritize sustainable funding for programs like Soteria. So just understanding a little bit more about how you're getting by now.
Yeah.
And earlier I said rich people donating. I want to just clarify that people like myself give you $25 a year, and that adds up. But you need a lot of money to run programs. Like, how are you able to sustain them currently? And what can the state do to help?
We could increase funding.
Just the agency in
No,
general?
it's challenging. I think every year, people who are doing human services come to the State House and say we need more money. I think it's a particularly difficult year when you must have heard this, the bagel shop is, the $25 to work at the bagel shop. So we're currently working with our funders to try to increase funding, so we can increase staff money. Anything you guys can do to increase the percentage that you give DAs and SSAs every year would certainly be helpful. It is a challenging environment that people are not being paid a living wage. Housing is in a crisis, and it's difficult for folks. We have a very mission-driven staff, as you can tell by what Jason said about people who've been through the program then come back around. So while we have staffing difficulties like everybody, they're not as challenging as some of the other places because people come to give back. So we're able to do that. But yes, we definitely are like every other agency and struggling with livable wage. Thank you for bringing that up, Ryan.
Follow up.
Yeah.
So on the, when we gave the DAs and SSAs last year an 8% rate increase, and we heard of this from Julie Tesler, did that also come to Pathways?
It came to Pathways for our Medicaid portion.
Obviously, yes.
So it didn't impact our peer services.
Okay.
And it didn't impact all of our programs.
Okay.
It wasn't across the board.
Medicaid.
Yes, so we got some, but it didn't.
And if we do that again,
That will,
Medicaid piece
yes.
will help, but there's a whole other piece.
It would be helpful to get the percentage across all programs.
Right.
I don't know the intricacies of that or what that would look like.
Okay. All right. Thank you.
The only other thing that I thought of is, because what I'm hearing is like you're funded by a combination of grants and fundraising. That it's not insurance, it's not Medicaid, other than what the state gives you for Medicaid, correct? The SSA payments or.
Yeah, that we do case rates with our housing
Yes,
first,
yeah.
and then we get a grant from them for like our therapeutic residents
Yeah.
as partially Medicaid money. Yeah.
So us increasing those rates would help. Us giving money to help purchase this property would be an investment in infrastructure that would help. I heard you mention housing, not only for clients, but also for staff.
Yeah.
And like, we're supposed to be building all this new housing. Has anyone engaged Pathways as a partner to figure out how to integrate housing, not only for clients, but also for workers into those new developments?
That's not, we're not a developer, so we're not, there's a lot of very smart people at those tables. Several of our board members are at those tables. So there's a connection and certainly conversations happening as part of the bigger community, but not specifically at a table about building housing, though we would benefit from more housing. It's certainly number one on my list, as I know it is on many of yours.
Yeah, I'm just thinking like if as we're developing people, like, and I'm not saying it's your responsibility. You have a lot of work
Yeah.
you're doing. That we need to take this into account because we could be building housing for both the workers and the clients in this housing, and instead of just building like luxury housing or whatever.
Yeah, I think it's really important to have mixed
Yeah.
income, mixed use buildings. That's certainly one of our highest values.
You good, Brian?
Yeah, thanks for letting me ask.
I want to clear one thing up. Maybe I misheard you. Did you say that you were not set up to take private money?
No, we can take private money. It's the insurance. We could, I'm sure if somebody came to us with insurance and wanted to pay it, we could do it. Maybe I misspoke. We don't have the infrastructure set up because it doesn't ever happen. The people we work with are mostly people living in poverty, and they have Medicaid. So we use Medicaid services or Medicare services. Does that answer that question?
No.
Yeah.
I'll give you an example.
Okay.
If I wanted to give you $1,
Yes.
could you accept it?
Oh, gladly, yes.
Yes.
And I give you a receipt that you could use for your taxes.
10,000.
You said you
Right.
couldn't get.
No, I was talking about that. I was talking about the healthcare, sorry. No, we did. No, we did. We were proud. I think Soteria has a lot of support internationally because it's a beloved model. It's a model that makes a lot of sense. It's the only one in the United States right now. There's like 6 or 7 in Israel and a handful across Europe, but we're the only one in the United States, which Jason and I are very proud of.
Yeah.
And I think Vermont's good at doing great things. So we just want a permanent home. We don't want to get the house sold out from under us, and we want a spot that's going to be here in perpetuity because people need it, and we want to increase the beds. We turn people away, and it's there's plenty of need. It helps with the emergency room story. It helps with people that don't want to go into the hospital. People, when you have a mental health crisis, when you have a break, when you start hearing voices or seeing things, if your child does, they're 18 years old and these things start to happen, there's not a lot of choices for folks. You go to the emergency room and you get thrown in the hospital. Soteria is like a little bright light on that in the room for that. You can, if there were a bed available, you could bring your child to Soteria, and it's a home-like setting, and it's staffed with lovely people like Jason, and you cook meals, and people can explore that experience in a safe environment and not be medicated and told what they have to do. They could choose medication if they wanted to, but they explore that experience for themselves. That's why we're here. We want to and it's a great deal. That building's $250,000. It's not a lot for a building in Burlington. It feels like a once a lifetime opportunity, and it's going to need a lot of rehab. But that's also an opportunity for us to build it the way Jason's vision is for what makes most sense. So we're excited about that combination.
I would just add, in terms of accessibility to services, if you have a child experiencing a level of psychosis, you may be given access to the hospital and you may not. The crisis screeners might decide that your child isn't experiencing a level of psychosis to which they are in danger of harm to self or others, and you can be sent home. And so I work with a lot of families who are in this stuck place of not being able to support their children because the level of crisis is quite high and intense, but they don't have access to really any services.
Art, and then Leslie.
Yes, this question might be for you, Lori, more than these folks. Is pathways, are the beds and pathways included in our mental health system of beds?
Yes.
They are. Okay, so the 5 beds you have are in the system.
It's on the bed board.
And
Sorry for the language, but that's how it put things in buckets so we can understand.
I know, and that's, I'm gonna go further.
That's right.
So Pathways is a DA?
So a specialist
SSA.
service agency. And so there's DAs and SSAs.
Right, correct.
And so when Julie Tesler comes in, like yesterday from Vermont Care Partners, they're like kind of the group over that DAs and SSAs.
Oh, okay.
That's a very good thing.
And now my question for you folks is, I read in your pamphlet here that almost everyone at Sotera suffers from an acute stage of psychosis. So these rooms must be locked. Are they locked? Are they secured? Is there security? So, people aren't, is there a danger here with people that live in these environments?
We have an extremely good track record of safety. So we don't have locked doors. What we have is robust staffing. So that our security is people, caring for people.
Okay, so you have people there, someone comes out and wants to, got a knife in his hand, wants to walk down the street. You
We
stop.
try not to have knives in the house.
Well, okay.
But you're.
I don't know. I'm just
No,
trying
that's a
to
good question.
understand, when I see suffering from acute stage of psychosis, I'm wondering, any neighborhood problems, anything like that?
We haven't had any problems. And I think the point to make here is that people experiencing psychosis are not statistically more dangerous than the average public, actually. I know there's a certain amount of fear and concern around people with psychosis for good reasons, but actually most people experiencing psychosis are probably more in danger of hurting themselves than anybody else, right? And so it's not as it's not as risky as it might seem to someone who hasn't worked with these people.
So on a whole nother track, you want to buy the house you're in?
No,
Different house.
Different house.
Different house, yeah.
In the same area?
Yeah.
Okay, all right, different house.
Because
Okay.
the
Fix it up and add 5 beds, or 4 beds.
add 4 beds, yeah. And the house we're in, we'd love to use for pure respite.
Oh, awesome. So you add beds there?
We would, that's my dream, is to keep the Manhattan Drive building for pure respite, which is, I think, coming up on some other of your bills around suicide. There's some money, and the Suicide Coalition put money in for pure respites, which we're big advocates of, yeah.
Okay, so the one you're in now, you own?
No, we're renting.
Rent, okay. So you're gonna keep using it, buy the other one, fix it up and put all 9 in there, or?
Yes.
Okay.
We'll have the capacity to serve 9. We'll have the capacity to serve that many people.
Okay, all right, just trying to understand the whole thing. Okay.
Leslie?
I'm really amazed at the work. I'm really amazed at how you have to put together the funding. That list just really sort of blew me away. But, so thank you for that work. It's pretty amazing. You talk about turning away 45 referrals. I'm wondering how many people you did serve over the year. Is there a sense of how many?
About a dozen usually.
Yeah, it's 661 since we've opened.
So you're thinking about 12 people placed in a year that.
People stay 3 months to 6 months, sometimes longer. So if you only have 5 beds and you have people staying 3 to 6 months, you don't serve a lot.
Yeah.
If we had more beds, obviously we'd serve more.
Yeah. So I just wanted to contrast to the 40.
Yeah.
Thank you.
And I don't know if you saw the cost, it's like 500 and something a night versus a hospital, which is 2,000 something.
26, 25?
Yeah.
Brian, did you have a follow-up?
Yeah, just,
And then Bobby, you had a question?
I wanted to say that I appreciate, earlier, Jason, when you said we go with them. And like we heard about, like from Wilda, I think the other day about like with peer support, the idea of walking with someone versus like doing something for them. And so I just wanted to highlight that because when we talk about like, I think a lot of people are afraid of, a lot of community members become afraid of someone when we struggle with mental health issues. And we get questioned, like our integrity, our safety gets questioned. But like the reality is that more violence happens towards people with mental health issues than, especially people if they're having psychotic episodes, people will take advantage of that. So I just appreciate that you stay with people through that. You don't call the cops and have them come take people away. You don't lock people in a room. I'm guessing you sit with them if they want it, and if they don't, you sit outside the room nearby so that they're there if they need you. But like
If they leave, we go with them wherever they want to go and maintain that safety. And again, we have an amazing track record. No one's ever been hurt as Soteria staff or residents in 7 years.
So I just really appreciate that. And I wanted to highlight that I heard you say that. And then the other thing is just around the number of beds. I was intrigued when you said you might still use the Manhattan Drive location because this place, it would be, you said it's adding 4 beds to your capacity, so you're going from 5 to 9. But then how many beds, would there be another 5 beds that possibly?
We don't have funding for peer respites yet.
Okay.
I'm just saying that's my fantasy that because I think I'm a big believer in investing in community supports, because if we have places where people can go in the community, they don't end up in the emergency room or in hospitals or in prisons or in shelters. So the more we invest in the community, and I think peer respites is a good way. Yeah.
You need to help me understand what peer respite means. I thought it meant that people from the new place that you're going to renovate could go and stay overnight.
No, I'm sorry, I confused the issue by bringing that up. I apologize. A peer respite is a place where we have one in Vermont right now called Alyssum. It's in Rochester, Vermont, and it's a 2-bed respite. So if people are struggling, they can go stay someplace that's safe. It's usually a 2-week stay. Up to 2 weeks. So it's not like a first break mental health story that is Soteria House that might take longer, 3 months or 6 months to work through. It's a place when you just need to get away. And it's a very successful model. We have states, New Hampshire, Massachusetts around us that have many more than we do. And those 2 beds are always full in Vermont. So we Vermonters that are interested want to build more of them so that it's accessible to more people, because I think it really brings down the use of emergency services.
Right. Most hospital stays tend to be 2 weeks.
Anyway.
And so I think that the model of the peer respite is to serve those people to take the load off short hospital stays.
So we have a couple more questions, but I do want to keep it focused on the Soteria House, sorry, because we need to move to something else. So Bobby and then Daisy.
Okay, well, this will just be quick, but do you serve people from just the Burlington area, or do you get referrals from all over the state?
All over the state.
Yeah, because I think this is such a great thing. I'm so impressed by what you guys are doing that I was hoping to see if you would expand, or if you've ever considered other regions of the state where you would want to have a Soteria House.
Well, yeah, we'll do anything where there's funding.
Yeah, no, I think I would like to bring this to the Northeast Kingdom.
Yeah, the Northeast Kingdom with Southern, it would.
I'd like to see one in every county.
Yes.
Yeah.
I'm for that.
Yep.
Daisy? And then Ellen, and then we're done.
To Topper's question, and also I think a couple of us are wondering if you can help orient us to where Soteria is in our mental health system of care. I don't know if everybody's familiar with this graphic. It's from Deputy Commissioner Crump's slides that she presented from DMH. It's sort of a tier with emergency rooms at the top, or intensive care level 1. And then down at the bottom is the community-based services. So we've been passing that around, wondering where Soteria House
See
is.
this here run, the third one down?
It's the one
Yes.
facility, okay.
Yes.
That's us.
It's in the middle, but it's
That one's the
not.
third tier all the way to the right.
least they
Pier
push
Run
it.
Residential.
And so Care Respite would be down at the bottom in community.
Pier Respite is, I don't know if I see it.
People always make hierarchies. Big circle instead.
Shelter. Youth group home.
So I'm
A
gonna,
residential, yeah,
I
maybe.
don't,
maybe the
I'm
bottom.
not sure.
so maybe you can reach out to Deputy Commissioner.
Allison,
Yeah,
I'm just trying to orient how far away it is from the emergency room.
yeah.
Because if we want to get folks away from there, like,
yeah, if you're investing in these, you're gonna lower these numbers, for sure, yeah.
This new location will be closer to the physically emergency room.
Okay, we gotta get moving. Alan?
Well, with just such small numbers that you can take in, the referrals, and you said the whole state, how do you go about when you get referrals, who's accepted at your place and who isn't?
We have an intake team, our intake coordinator, and depending on what beds are available, what's going on in the house, you guys, there aren't that many openings, so it's hard, yeah.
But we get referrals from everywhere, from crisis screeners, from the hospital, caseworkers, and then also just individuals calling us and saying, I heard about your program, I think it would be right for me. Often families will, be supporting a adult child, an adult offspring. But yeah, so but that's part of our flexibility is we can take a referral from anywhere.
Great. Thank you both. This is very informative. We appreciate your time and all of your work that you do for Vermonters.
And you too.
Thanks for your time.
Thanks.
thank you.
Yeah, very much so.
And Daisy, if you can reach out to Allison and get that answer, that would be great. All right, we're gonna switch to our COVID flexibility bill. We're gonna vote, so if you're ready for that, Mari.
I am.
At some point here. So Jen provided an updated document. And just to remind everyone what I said the other day, due to the timing of this bill, we are, taking the radiologist piece out of this, and we will be addressing that as a separate crossover. And then we heard back from, I heard back from the Chair of Human Services regarding the buprenorphine and the advanced directives, and what she would like us to do is keep the same language that we had, and Jen will go over this, keep the same language we had in the last act and simply extend the dates. And they will be taking more detailed testimony for the changes that the advocates wanted. But they want to keep what is available going forward for a year. So with that, I'm going to turn it over to our legislative counsel to walk through anything about the bill.
All right, thank you. Jen Kirby, Legislative Counsel. And Claire, I'm in the waiting room. And I will put this up. Well, I guess let me in and make me go. Great. Thank you. All right, so I have brought you a new, this is draft 4.2. I had a 4.1 and then I made a non-substantive change after talking to editing, just about where some heading and some asterisks go. So this will be 4.2. Okay, here we are. All right, so hopefully you can see that. So I have just put some highlighting in for what is different, and I think or really what the new provisions would be. So I did not show anything in here about radiology assistants. They just came out. Radiologist assistants, they just came out. But from what you have looked at before, there is new language. So this is one of the things that's different. It's just this section heading I put back where it originally belonged. But buprenorphine, instead of, we'd looked at codifying language last time that would allow a healthcare professional to renew authorize renewal of an existing buprenorphine prescription without requiring an office visit, and would added some additional language and would have had that in place on an ongoing basis. This instead just takes the session law provision originally enacted in Act 91 and extends it from March 31st of this year to March 31st, 2024. And then the rest of the issue can be addressed in Human Services if and when they choose to do so.
Wait, hold on. Got a lot of hands going up. Topper and then Alan.
I just want to make sure that there is an in-person visit in the beginning.
That is my understanding. So we don't have to my knowledge, we don't have a specific requirement in state law around how the office visit or the prescription renewal process works. It's all really done at the federal level. So this is piggybacking on existing federal authority.
Yeah. In my mind, I'm remembering, and I don't know if I'm remembering right, that there had to be a personal visit in the beginning, and after that, the telehealth could take the place of that personal visit.
That is,
But if I'm wrong,
Well, it may authorize renewal of a patient's existing
right,
buprenorphine prescription.
Yeah.
let's see. I think that would be, it's a good question. I don't have an answer. I had started to look into it and reached out to Katie, who I think was going to reach out to the health department, but I don't see, not sure if or when we heard back. So I'm looking in my emails right now to see if I can get anything useful. Nope, but I can follow up with the health department directly.
Alan?
Maybe you guys can just help me understand. Why would an office visit not be required once you have your initial? It just don't seem to make sense to me that,
Are you talking specifically for buprenorphine or generally?
yeah.
I mean, I think to the extent it's allowed under federal law, it's really a policy question of whether you want somebody to, I think you could view it as a potential barrier to access or to continued adherence. But I think there are policy, I mean, it's a policy
I know it's
decision.
federal, but it just doesn't seem, things change, people change, needs change, and it just don't seem to make sense to me.
Alyssa, can I give an example? Sure. So, I mean, when you're getting buprenorphine, very limited supply that you have to have on that day. And if, for instance, you happen to have COVID, you would not be allowed into a doctor's office. And so therefore you have to get a prescription, so you could do it through telemedicine, or a prescription could be sent in for you without requiring the office visit. Because if you don't have it that day.
And I understand that,
Yeah.
but for how many years?
Well, yeah, but this,
So again, this is still under the guise of the COVID flexibility.
Right, and I
We heard
understand
testimony
it's federal,
that there's
yeah.
still an issue. Again, the intent is that we, as I've said before in front of the stakeholders and what I've talked about with Human Services, is that this will be an extension if we approve it till 2024. And the intent is either it goes away or it becomes permanent based on the policy of the Human Services Committee. Mari.
There are many health visits that used to be in person that are now telehealth and that are done well, and the providers are very skilled at knowing whether or not a telehealth visit is appropriate. And many of those visits include medication compliance follow-ups. And so it's a telehealth appointment, and in some cases, or nothing. So it's really an essential tool.
Leslie?
just to add on to what Mari's talking about, a lot of times people treated are very stable. They're in a system of their issues are being treated with buprenorphine, and there's not a crisis around what's going on with them. So they may just be able to be seen very quickly in a telehealth visit to continue the prescription so that they stay stable and able to do their life.
And let Jen stop typing.
No, that's okay. I'm
Okay.
emailing the health department to ask the question about the initial prescription, so we may have an answer.
And then the other thing that we have to remember is this is already in effect.
Yes.
You know, these people during the COVID thing were getting the buprenorphine through a televisit.
The renewals, right.
Renewal,
Right,
excuse
yeah.
me.
Yes.
Right, so this is extending that authority for an additional year, although that may be addressed and modified in a different way by the committee down the hall if they take it up.
Okay.
All right. The other change, again, really just preserving the larger issue for the Human Services Committee is down here under advanced directives. And so I have, as you may recall, in the intervening drafts, we had codified kind of on an ongoing basis the ability to have remote witnesses and explainers for advanced directives by taking off the end date and then creating it as kind of an ongoing process. Instead, here we've gone back to having an end date. So saying that notwithstanding our regular advanced directive witnessing requirements, an advanced directive executed by a principal between June 15th, 2020, and then just extending that date out a year again, March 31st, 2024, would be deemed valid even if the principal signed outside the physical presence of one or both witnesses, as long as certain conditions continue to be met. And the same thing is true, would be true for advanced directives executed by a principal between the beginning date and March 31st, 2024, while the principal was being admitted to or was a resident of a nursing home or residential care facility, or was it being admitted to or was a patient in a hospital, even if the explainer was not there physically present in the same location with the patient. So I have changed the section heading name to take out specifically the references to COVID-19 and put instead remote witnesses and explainers for a limited time, which again may get changed down hall, but will be amending statute.
All right.
I'm a little chagrined because I don't remember why we didn't extend it permanently
Yeah.
instead of just extending it just to
Because
2024.
human services would like to take testimony on it and they
Okay.
haven't had time and we need to get this bill out.
Makes
Pretty
sense.
much what it is.
Okay.
Yeah.
So I have saved all of the language I drafted for the other version so that I can put it in something for them if they
Thank you.
go that direction, yeah. And then the other thing we had talked about the other day was whether we needed to change references to COVID-19. And specifically, the only place it really came up was in the emergency rulemaking authority for DFR. And after conferring with them, it seems like that does not need to be changed. It can stay as COVID-19.
Great. Thank you for checking on that. That was a good question.
I think they had a suggestion that I was concerned would be unnecessarily limiting, and they said, COVID-19 is fine. You can leave it like that.
Great.
And that's it. So I renumbered the sections. So if the effective date section is now section 7, and it doesn't have the exception for a piece of the advanced directive language. It would just be a straight up effective on passage.
Great. All right. Any questions, comments before we vote? Art.
Yeah, I'm gonna vote for the bill. But I don't like it a lot, I have to say. I just don't think we need to continue the thing. But I will go along and vote for it, even though I'm not in love with all the provisions.
And we will make sure that, as I said before, that next year if this comes.
Yeah, I was gonna say, I will not be voting for this next year, that's for sure. So, yeah.
Thank you, Art. All right. So does anyone want to make a motion?
To approve committee bill as amended.
Mari, second?
Second.
Oh, can you do a motion?
I don't
or
think
no?
I can.
Okay, you do it.
I'll make a motion that we approve this committee bill as amended.
Second.
Great. You can,
Representative Burbecko,
Yes.
Representative Chena. Representative Cordis, yes. Representative Demar,
Yes.
Representative Farlise Rubio,
Yes.
Representative Goldman,
Yes.
Representative Peterson,
Yes.
Representative Black,
Yes.
Representative McFawn,
Yes.
Representative Houghton.
yes. And we're gonna just wait 1 minute.
Can I ask a question? This is.
Not-
Not in the middle of the vote.
I'm gonna just take. Okay, we can close the vote.
Okay, the vote passes on a vote of 9-0-1.
Great. Thank you, Mari. We did not talk about a reporter of the bill. If anyone wants to volunteer, I will also say I've done all of these for the committee in the past, so I'm also happy to volunteer, but I'm also happy to give it to someone else if someone wants to do it. All right, so I will be the reporter of the bill.
And there was a,
Yeah, you can ask your question, Melissa.
I'm curious where these votes live. Like if, I mean, they're being recorded, they get sent to the clerk. If someone wanted to access them, they have to go to the clerk. It's not on any public
It
record.
would be on the House calendar from when we took it up.
But just the numbers, I'm just thinking about the
the
individual.
actual votes for
Yeah.
from the individual members. I think that you can ask the clerk. It's a
They
public
watch the
record.
video.
Oh, wait,
Claire has them?
Claire has them. The committee assistant maintains them from previous years. Yes.
So, Madam Chair, I'm going to be sending you the clean version of the draft 4.2 that we just looked at. Because it's a committee bill, you need to send it to drafting operations.
Okay.
I will copy them as well.
Okay. And do I need to tell them something in particular?
We
can do this.
Yes.
Too. So we'll do this offline. Okay, so let's take a